Hello, this is Rockson Liu from Emeryville, California, dedicated hernia surgeon. So in the last video, I kind of talked about open versus lap versus robot surgery for inguinal hernias. And I want to kind of continue talking about inguinal hernias. This is still the first part. Second part, I'm going to talk about ventral hernias. But when it comes to inguinal hernias, like I had mentioned in the last video, you should really ask for robotic repair because I think it's the best. I didn't mention last time that there's also less chronic pain with minimally invasive hernia repair. Studies are bearing that out, that with open repairs, you're going to have more chronic pain than robotic or laparoscopic repair. So there really is no reason in my mind for a person to have an open repair, unless you can't tolerate general anesthesia, unless you want a tissue-based repair, which is done open. Otherwise, you should have a robotic repair. Now, speaking of tissue-based repair, there are a lot of concerns regarding mesh. I would say I spend most of my time talking to patients about mesh. And that's one of the reasons why I actually became a dedicated hernia surgeon, because there's so much information online, whether it's factual, whether it's made up, whether it's real, not real, whether it's bending the truth, whatever. There's a lot of information, and it's impossible for the average person to try to figure out what is important, right? Even doctors have a very hard time figuring out what is the best repair and whether mesh is safe or not. I get doctors in my office all the time like questioning the use of mesh, and the literature is pretty consistent in that polypropylene or polyester meshes, permanent meshes, are very safe. Okay, as a hernia surgeon, very experienced hernia surgeons, I deal with people's complications and I deal with patients with complications. I would want a piece of polypropylene mesh in my groin. Okay, my partner, who I did his surgery, requested polypropylene mesh, and we are very experienced hernia surgeons. We see chronic pain, we see patients with complications, and I can tell you, a lot of the concern that you read online or hear from your neighbor or your friend are overblown. Okay, there's very little evidence that polypropylene mesh is an issue, and this goes back to kind of how I started this series in saying that most of the outcome of surgery is determined by what happens in the operating room, right? What the surgeon does, the judgment they make. And I can tell you, when it comes to putting in an implant, the surgeon's skill, their ability, their judgment is extremely important. So if I have a piece of mesh and I lay it flat in the space, and when I'm done with the operation, the mesh is laying in a good position, nice and flat against the abdominal wall, it's going to have very little issue. Okay. If I don't create a big enough pocket, okay, whether it's for a ventral hernia or an inguinal hernia, and the mesh goes in that pocket distorted, then it's going to have ridges, it's going to have folds, creases, it's going to have pointy areas, it's going to have high ridges that can press into nerves, into the abdominal wall, into tissue, and it can cause pain. If the mesh is not laid around the hole properly, if it doesn't have good overlap, then the hernia can come back easily. The sac can push the mesh into the hole, or it can just work around the hole. So the issue of mesh migration, it's not really the mesh migrating, it's the mesh not being placed properly, right? The issue of mesh wadding up, right? People think that, the mesh is contracting and it turns into this ball. It's not because the mesh itself did that. It's because the surgeon placed it in, it crumbled up, right? And so it slowly contracted and became a ball. So a lot of the mesh issue arises from technical problems in the operating room. And this is why it's so important to know who your surgeon is and what they do in the operating room. And if you had watched my previous video, I gave you a lot of clues as to how to find a surgeon who does a good job technically in the operating room. And that's what you need to know, right? But okay, having said that, people are still afraid of mesh, and I don't blame them. We're worried about microplastics nowadays. We know that, there can be issues with that, and I respect that. And my job as a dedicated hernia surgeon is to know as much as I can about hernias, right? And I can then have a real conversation with patients. I spend time finding out what the patients care about, right? What's important to them, right? Is it fast recovery? Is it getting back to, playing with their kids? Is it getting back to work? Is it getting back to the gym? Is it getting back to running a marathon? Or is it avoiding permanent mesh, right? So everybody weighs, things differently. And my job is to know the science, right? Have the experience, and then meet the patient in the middle and say, okay, what's important to you and what's not important to you. And for some patients, not having permanent synthetic material is the most important thing to them, right? They don't care whether they have open surgery, whether the chronic pain rate is higher, whatever, right? Things that maybe are important to me are, secondary to them, right? So in that case, we have options. So if you don't want permanent mesh, there's open surgery with very well described tissue-based repairs, right? There's, Schuldeis is the one that I do most often. There's Bassini, McVeigh. There's all different types that have eponyms, meaning they're tied to a surgeon's name that first described the operation. So those are options, and I would say those are good options. It's not what I do all of the time. Of course, I do mostly robotic surgery, but I have been in practice for 20 years and have done plenty of tissue-based repairs. I can say I'm doing it more often now because more patients are requesting it, and it's a good repair. The recovery is a little longer, but not that much longer. And the recurrence rate, again, we don't have a registry, so these patients, they seem to do well for a few years, and then they kind of go off and disappear. So they seem to do well. I will quote the recurrence rate at about probably 7-8% because that's what the literature quotes. If you go to the Schuldeis clinic, they say that their recurrence rate's less than 1%. But I know they're very picky about who they operate on. You have to be a very thin, healthy person. And I would say a lot of patients don't meet that criteria, right? So to get the less than 1% rate, you need the ideal patient. And of course, in the ideal patient, we all have really good outcomes, right? So, but tissue-based repair is a good, solid option. We also have robotic options now because we have hybrid or resorbable meshes, right? A hybrid mesh is one where maybe most of the material kind of gets remodeled or disappears or gets reabsorbed. But there's still some synthetic material, like a little bit of suture weaved into it. So there's a lattice or rebar that your body can kind of grow tissue around, right? So that's a nice kind of midpoint type of mesh where not too much permanent material, but there's still a little permanent material to add some strength, long-term strength. And then there's fully resorbable mesh like Transorb and Phasix that completely disappear. They both are very different materials, but they have and different science behind it. But what you have to keep in mind is that with an inguinal hernia repair, we really don't close or sew a defect or a hole close, right? The repair itself is the mesh. It's blocking the hole. So if that mesh disappears, the hernia may come back. Now, I think in smaller meshes, like femoral hernias or very small inguinal hernias, direct and indirect, I think it's a good option because the collagen, the scar that the body lays down should be strong enough, to support the repair for a small defect. But for the larger defects, that's a little different. I think as a surgeon, I need to do something else other than putting the mesh in. I need to take the transversalis fascia for a direct hernia and try to kind of reconstruct the defect a little bit. The lateral internal ring, there's some stuff that can be done, but I think a surgeon does need to do a little bit of extra steps to make sure the hernia doesn't recur. But as a surgeon, I am a little concerned about recommending those repair for everybody, because I think the recurrence rate is going to be higher. It's possible it could be 100% with those fully resorbable meshes. We just don't know because there's no data out there. But for patients who really don't want a permanent material in their body, who want fast recovery, who want low chronic pain rates, then I would say a robotic repair with a fully resorbable mesh or a hybrid mesh is an option. So that's all I'm going to talk about today. Next video, I'll probably start talking about ventral hernias, but if I think about some other inguinal hernia topics, I will bring it up too. Okay? So stay tuned. Thanks for watching.